first thing to say that in the title of the abstract, we're talking about white matter hyperintensity. That's not true. We have to say white matter hypodensity, since we focused on non-con CT. We did a sensitivity analysis on MRI. So it's actually white matter hyperdensities instead of hyperintensities. That being said, so in this study, we included patients from the ESCAPE-NA1 trial, which is a well-known large randomized trial, placebo-controlled, that looked at the effect of neurantide. And this is a retrospective study, and we included more than 1,000 patients. And we looked at the burden of white matter disease in the periventricular as well as in the deep white matter by using the Fazekas scale. And we looked at the association with outcome after EVT, since all the patients underwent EVT. And I would say the added value of the study is that it's actually twofold. So first of all, we included multiple time point assessments. So at day 5, day 30, and day 90, we had trained personnel who assessed the MRS, so the modified ranking scale. And this allowed us actually to disentangle the relationship between white matter disease and outcome much better, as opposed to single time point assessments, because the problem with single time point assessments, especially with white matter disease, is that adverse events could have happened within the time frame of the EVT and the outcome assessment. And if you have multiple time point assessments, then if you see a difference in the first period, so let's say until 30 days, and you see a difference in 30 to 90 days, then this gives you a more clear association of the variable of interest, so white matter disease, and our outcome. And secondly, we also looked at brain atrophy, and we looked at chronic infarctions, and we adjusted our analysis based on for these imaging features of brain frailty. The main findings of the study is that we saw that patients with higher white matter disease burden had worse functional outcome in every time point, so worse functional recovery compared to patients without white matter disease burden, even after we adjusted for age and other markers of brain frailty, such as atrophy and chronic infarctions. And so these data may further help inform treatment expectations and recovery-related planning by using pragmatic and easy to implement scales and measurements on a non-con CT. So we did the same study method on patients, on the same patients, where we looked at brain atrophy, and we adjusted for features of small vessel disease, such as white matter lesions. And we found, again, similar results. Patients with higher levels or burdens of brain atrophy regarding the GCA scale, the global cortical atrophy, had worse outcome at each time point, even when adjusting for age, but also for imaging features of small vessel disease, such as white matter disease. And we found, we also did an atrophy assessment of each lobe, frontal, temporal, occipital, and parietal, and cerebellar, and hippocampal volumes, and we found no significant differences regarding outcome compared to different lobes.